Hey health warriors, when your patient is in distress and can't catch their breath, every second counts. Today we're breaking down respiratory failure, specifically the difference between acute and chronic, how to interpret the ABGs, and what treatment strategies can make the difference between stability and a rapid decline. Respiratory failure occurs when the lungs can't exchange gases effectively, either not enough oxygen is delivered or carbon dioxide isn't removed. Acute respiratory failure happens suddenly and is often caused by pneumonia, PE, asthma exacerbation, or trauma. The ABG shows a sudden drop in PaO₂ or a rise in PaCO₂, requiring rapid intervention. On the other hand, chronic respiratory failure develops over time, often in conditions like COPD, neuromuscular disease, or obesity hypoventilation. The body compensates with renal bicarbonate retention, and the ABG may show elevated CO2 with normal pH, indicating compensated respiratory acidosis. Knowing whether it's acute or chronic affects everything: how you respond, how fast you escalate care, and how aggressive you get. Alright, so let's dive into ABG interpretation. When you see PaO₂ less than 60 millimeters of mercury, think hypoxemia. If PaCO₂ is greater than 50 millimeters of mercury, that's hypercapnia. Now, if the pH is less than 7.45, it indicates acidosis, especially if it's acute. And if you notice elevated bicarbonate levels, consider chronic compensation. These are key points to remember when interpreting ABGs. Always correlate arterial blood gas results with the clinical presentation. Pay attention to SpO2, respiratory rate, work of breathing, and mental status. When it comes to treatment strategies, here are some key points to remember. For mild cases or exacerbations, consider supplemental oxygen, inhaled bronchodilators, and steroids. It's also crucial to treat the underlying cause, whether it's antibiotics for infection or diuretics for pulmonary edema. In cases of ventilation failure, non-invasive ventilation like BiPAP or CPAP can be very effective. It's important to monitor arterial blood gases closely after 1 to 2 hours and watch for signs of worsening fatigue or altered level of consciousness. If BiPAP fails or the patient crashes, you must prepare for intubation and mechanical ventilation. Keep an eye out for complications such as barotrauma, ventilator-associated pneumonia, and issues related to sedation. The nurse's role is absolutely vital in managing respiratory failure. Frequent respiratory assessments, including respiratory rate, lung sounds, SpO2, and accessory muscle use, are essential. Monitoring arterial blood gas trends and the patient's response to treatment is also critical. Communication is key. Report any changes in level of consciousness or worsening dyspnea immediately. Additionally, supporting both the patient and their family, especially in chronic or palliative cases, is an important aspect of care. Respiratory failure can escalate fast, but when you understand the cause, oxygenation versus ventilation, you can act with confidence and save lives. What's your go-to tip for managing respiratory failure at the bedside? Drop it in the comments below. Subscribe, and follow for more practical nursing breakdowns that help you lead with clarity and care.